So Greg's right that there's not as much data in the T790M negative setting. I wanted to pull it back a little bit and cover some related questions that I think apply in general to changing therapies in acquired resistance, and really broadly asking, in a setting where we don't have as many clear options, one question is, do you need to make a change at all? And this has come up already over the course of the day, but just to say there are different criteria, and if the criteria that you're using are a rising serum tumor marker or PET uptake, I would not consider that to be a clinically significant change. It really matters whether there's a progression seen on the CT, and if not, I wouldn't change therapy based on that. I would even ask, do you need to squint to see the difference? Because if you are seeing if you have to squint to see a 1 millimeter change, that's not enough to really bother changing directions on. And so if you do have that, I think the question should then be, is it one spot? Is it multiple spots? And if it's one spot, or if it's a place where systemic therapy changes are hard to affect, like the brain, it's very reasonable to pursue a local therapy, whether that's a stereotactic radiosurgery in the brain, resecting a new lung nodule, or ablating it with stereotactic body radiation therapy. If you have excellent disease control as the backdrop and just one area progressing, I think it's very reasonable to use a so-called weed the garden or spot welding approach, and really only change systemic therapy when you have a multifocal progression that is really clinically significant. And just to underline this is a report that was done by Jeffrey Oxnard, 42 patients in up to 3 clinical trials in Boston, and found that a significant minority of patients were able to just have focal radiation or surgery and could go on for more than 3 months without any need to change anything, and even about 1 in 5 going a year or more. Now, this is really only being selected for patients who have very limited progression, but it does say that it's not something reflexively that you would want to make a change in systemic therapy just based on progression at all. So there's degrees of progression, and I would say that local therapy in the setting of acquired resistance is an appropriate consideration, particularly when you don't have some well-established next treatment waiting in the wings. And it's I think, important to wonder whether these patients, you would do just as well without treating a little lung nodule that happens to be growing, but there's a place for clinical judgment. Another issue, and perhaps it comes up more by default when you don't have a next therapy like Ruxolitinib or osimertinib, is do you want to start chemotherapy, and should you continue your EGFR inhibitor with it or not? And up until recently, we've had very little data, largely looking back at old series of patients at one institution or another. And this is a retrospective review of 78 patients that suggested that the response rates were better by adding chemotherapy and continuing the EGFR TKI compared with just an outright switch to chemotherapy. On the other hand, there was a phase 2 trial that ended up closing with relatively poor accrual, and this was not specifically looking at EGFR mutation positive patients, but just at patients who hadn't progressed after at least 12 weeks of erlotinib, Tarceva, and there was no real difference between continuing the EGFR inhibitor or not. I would say the best data we now have for this is from the IMPRESS trial, which is of chemotherapy everyone who had progression on Iressa for an EGFR mutation would then go on to receive cisplatin and Alimta, pemetrexed, with or without ongoing Iressa, and there was a placebo control for the patients who didn't get Iressa. And the primary endpoint was progression-free survival, and as it shows in the bottom, there was no difference between the two arms. You got no benefit from continuing with gefitinib compared with just getting placebo with your chemotherapy. But it's interesting, and this is work that just came from the World Conference on Lung Cancer, where Greg and I were a month ago. And when you look at the data, depending on whether patients had a T790M positive progression or not, there may be differences that suggest a benefit for the patients who were T790M negative and continue their EGFR TKI, compared with really no hint of a benefit seen in those who are T790M positive. So that is provocative, and it's a subset analysis that isn't quite statistically significant, but whether it would affect treatment decisions is a matter of debate. Another issue that has come up and really made us wary about continuing an EGFR inhibitor after switching and starting chemotherapy is a suggestion that there may be a trend toward a worse survival for patients who got chemotherapy concurrent with ongoing EGFR inhibitor. And when Dr. Mock and colleagues looked at the data from the IMPRESS trial and survival as a function of whether you were T790M positive or not, there does seem to be a detriment to survival with the combination of ongoing TKI and chemo in the T790M positive patients, but not in the T790M negative. It's not to say that there's a survival benefit with T790M negative disease, but that concerning potential association with worse outcome seems to be limited to those who are T790M positive. So in this setting, not sure what to make of it, but it would really suggest that that you would be highly disinclined to continue an EGFR TKI with chemo if you know that you are T790M positive. Fortunately, you'd probably be inclined to switch to a different agent like osimertinib or ruxolitinib instead. And then finally, looking at response rates with the combinations, just to show that the numbers are a little higher actually in terms of response rate to chemotherapy alone or chemo with a TKI in the T790M negative patients compared with the T790M positive patients. Another question is whether you can do chemotherapy and then go back to retreat patients with something they received previously if we didn't have some of these new agents available. There are various studies, small series that have been published, but they really show response rates that are quite low, about 10%, 5-10%. There's usually one or two stray people who do respond. It's usually a short-lived response with a progression-free survival less than 4 months. So in theory, there's a case report out there, here or there, showing that patients can resensitize to an EGFR inhibitor after a period of time off of EGFR inhibitor therapy, but not a lot of data on the subject. Here's one retrospective look at 24 patients over a decade and showing a response rate of just 4%. There's certainly some patients with stable disease, but whether this is really more just slower progressing cancer anyway, it's not clear whether the EGFR TKI is really adding much. Here, the median interval off of TKI therapy was just 5 months. Not surprisingly, if patients are off of therapy for longer, they tended to be more, that tended to be associated with a better chance of response. This is a a Japanese series that looked at 73 patients with acquired resistance, although in some cases, and it's really quite a few, they had brain metastases, and it's not really clear how much of it was really acquired resistance, but this issue of not being able to penetrate into the CNS. And they did see a better survival in patients who went back onto EGFR TKIs, but with several of these patients actually perhaps just being patients who got treated with radiation for brain metastases, I don't think that it had really squeezed out all of the benefit at all from these treatments, and it might have just been quite premature to stop it. But this, at the very least, suggests that we shouldn't be in any great rush to stop a therapy that has good extracranial control if you develop intracranial metastatic disease. In terms of other options, some have looked at afatinib, Gilitrif, after patients have previously been on Iressa or Tarceva. This is the Lux-Lung-1 trial. It was a 2-to-1 randomization to afatinib or placebo after at least 12 weeks on one of these therapies without progression, and it wasn't specifically looking at patients who had an EGFR mutation necessarily. It showed an improvement in progression-free survival from really poor to so-so. It looks like a big difference, but it's 1 to 3 months. And there was no improvement at all in survival. In fact, the blue arm that looks a little better, but not significantly so, is the placebo arm. And because of that, I really have no enthusiasm for afatinib as a single agent after acquired resistance to gefitinib or erlotinib. It's not, to me, an approach that I would consider to be very, very compelling. Now, afatinib and cetuximab as a combination has been looked at, and there's certainly been more enthusiasm for that. And this is the results of a trial that was done at Memorial Sloan Kettering and a few other settings. Dr. Riley probably has a few patients who were on this with afatinib and cetuximab. It was published by a colleague of his, or presented and I think subsequently published by Jen Jigian and colleagues. And the response rate's 30%, but you can see that lots of those bars are going down more than 30%. So certainly some suggestion that there was that this is a very active regimen. Now, a caveat is a lot of these responses were relatively short-lived. I think that the median progression-free survival of in the trial was about 4 months, so it's not something that had particularly sustained responses. Now, there's also the color coding, and it's T790M positive or negative. The preclinical data would have suggested, actually, that the results that the combination would be particularly effective and maybe only effective in T790M positive disease, but you can look at these bars and see there's not a clear pattern, that it was really comparably effective in patients with or without T790M positive disease. And so, unfortunately, we really haven't seen further research come out in the last few years since this was initially presented with a few dozen patients, but we do need to get more information, and this would suggest a potential valuable approach for patients with T790M negative disease, but we do need more information, I would say. Now, this is called the Mission trial. It's almost never been discussed or thought about since it was overall negative, looking at sorafenib versus placebo in previously treated patients. And it was not primarily looking at EGFR mutation positive patients, but they looked at a subset, or they looked at the results based on whether you were mutation positive or not. And a quarter of the patients did have an EGFR mutation, and that was associated with, as you can see on the left, an improvement in progression-free survival with sorafenib, and really not as compelling in EGFR wild type. When you look at the overall survival, the same holds true, that it's really an impressive doubling of median overall survival from 6.5 to nearly 14 months. Now, we haven't seen any further work on this done, but I would say that that's certainly a provocative finding that we really haven't talked or thought much about since this came out. But, and we certainly don't know about patterns of acquired resistance, et cetera. So another option is AUI-922, which is an HSP90 or heat shock protein inhibitor that is not commercially available, but it's been looked at by Melissa Johnson and colleagues in combination with erlotinib. And as you can see, there aren't a lot of bars on this waterfall plot, so it's really small numbers of patients, but at least a proof of principle that you can have patients who have good shrinkage of their cancer with this combination after previously progressing on erlotinib. And it's not only in patients with T790M positive disease. The toxicities are shown here: diarrhea, fatigue, night blindness as an unusual side effect of some of these heat shock protein inhibitors. So this is something that would be nice to get some further development on. So Dr. Riley pointed out that osimertinib and ruxolitinib have really completely reinvigorated the world of acquired resistance and provided great options for those who are T790M positive. But this is the waterfall plot for T790M negative disease, and you can see that there are quite a few patients who have who have a tumor shrinkage, as you can see here, even T790M negative disease. And here's the results with ruxolitinib. As Dr. Riley noted, the duration of these responses has tended to be quite a bit less, but you certainly can get responses that are not limited to patients who are T790M positive. And I would say that Clovis has been moving forward a little faster in terms of developing this approach for patients who are T790M negative. This is a presentation from World Lung last month by Heather Wakely, looking at T790M negative patients by tissue, showing a very nice tumor shrinkage in a fraction of patients here, and the response rate is about 33%, so about 1 in 3 patients, and about a quarter when looking at plasma. And again, still plenty of patients with downward going bars on the waterfall plot. So it's worth bearing in mind that, as we talked about, the waterfall plot shows proportional tumor shrinkage to the length of the bar, but many of us would be very happy to see a nice downward, nice tumor shrinkage, even if it doesn't meet the threshold for a partial response. So these numbers that you see for overall response underestimate the proportion of patients who are benefiting, and that's also shown in part by this difference between the overall response rate and the disease control rate, or DCR. So here you have 25% with significant tumor shrinkage, but 75% with stable disease or some degree of shrinkage that does not meet the higher threshold for significant shrinkage. And again, here you have twice as many patients, 1 in 3 patients with major tumor shrinkage, but 2 in 3 with minor shrinkage or stable disease. Just closing out, a couple of other options. One is this agent TH4000 from Threshold Pharmaceuticals, and this is a pan-HER inhibitor. That is, it inhibits multiple receptors in the HER family, which is human epidermal receptor. EGFR is one of those. It's HER1. You've heard maybe about HER2 or HER2/neu, which is another one of the family that's very relevant in breast cancer, HER3, et cetera. And so this one is activated in a hypoxia setting, that is low oxygen levels, and that is relevant for many tumors because they're growing and they don't have a good blood supply, and there's a problem with sometimes getting active drug working and delivered in the places where there's just not good oxygen levels. And so this is an agent that is specifically activated in the setting of low oxygen levels and may be particularly active. Is certainly some preclinical work suggesting that it could be very active in patients with acquired resistance. And it's actually being studied at my center and several others through what's called ATOMIC, the Academic Thoracic Oncology Medical Investigators Consortium, with institutions shown here, really various places around the country, specifically looking at T790M negative disease. So fortunately now with this and with some of the work being done on other third-generation inhibitors, we're having a few more options, at least in the realm of clinical trials, and hopefully actual drugs available for patients in the future. The last one I wanted to mention is an antibody against HER3, which is, again, one of the family. And these the importance of these various receptors, HER1, HER2, HER3, and HER4, is that they so-called dimerize. They pair together on the surface of the cell and then lead to signaling. And so HER1, or EGFR, definitely interacts with other members of this family, and it's not just a story of HER1 alone. And HER3 can pair with EGFR, and patritumab is an antibody that blocks HER3. Now, in preclinical studies, it can have good activity inhibiting the EGFR signaling pathway. Whether this applies in the setting of acquired resistance has yet to be determined. Now, there's a trial that is looking at patritumab in combination with erlotinib, but I believe that is being done in a treatment-naive setting. We have yet to see whether it would work in acquired resistance, but it's an interesting question. So in terms of options for the T790M negative patients with acquired resistance, I would step back and just clarify whether the progression is clinically significant and merits any intervention at all. If so, is it so limited that local therapy is more appropriate than systemic therapy? If systemic therapy change is indicated, then chemotherapy is still a very appropriate consideration. And it's worth remembering that response rates with chemotherapy or to chemotherapy in patients with EGFR mutations are consistently at least as good as we see in other patients, and in some trials are better in the EGFR mutation positive patients than in most patients overall. In terms of whether to retreat, it's probably minimally effective. There's not a lot of evidence about not enough evidence yet about continuing the EGFR TKI, but the IMPRESS trial suggests that it's not a great idea, and particularly not, at least for patients with T790M positive disease. Afatinib and cetuximab is an approach that really looked provocative and encouraging a few years ago, but we need more information on it, and I'll be interested in Dr. Riley's sense of tolerability of this regimen as well. The third-gen EGFR TKIs, rosiletinib and osimertinib, leading that charge, have been primarily focused on T790M positive disease, but both have activity in T790M negative, and we need to explore that far more. And then there's a few studies that are going to be moving forward in T790M negative disease, particularly TH4000. I'm interested in patritumab, but I haven't seen that move forward yet. And so there's good reason to be hopeful about the ever-growing range of trials and hopefully soon commercially available options, not just for T790M positive, but for a broader range of patients. Thanks very much.